Namaste, good afternoon. I'm very happy to be here. And why? Because CSI thought that they are looking for cardiac MRI. It is a one-stop shop. And believe me, I had an opportunity to start first MRI in India, cardiac MRI in India, at Bridge Candy Hospital, 1987-88. Mona Bhatia is here. And things have grown so big here. So I'm very happy and elated because of that things are changing today with the cardiologist also. Now, most important, the quality of image is the only crux of everything. If quality is bad, I'm bad in MRI or CT, whatever. So that should be the idea. Now, most important today, what we can do with the cardiovascular CMR is morphology, excellent, ventricular function, no doubt at all. Myocardial perfusion is very good. Tissue characterization is very high. Flow quantification and coronary artery disease. And today, with the help of VCG, image quality have changed totally and noise is not there at all. Now, let us understand, you are looking for 3 Tesla, 7 Tesla, you need a 1.5. With my experience, with good software, 1.5 Tesla is good enough for today, considering the cost to the patient also and cost to the doctor also. Why CMR for Levy function? Standardized imaging planes for the heart, left ventricular function imaging protocols, and why it is one-stop really. So you should know the advantage of CMR in a big way. Q-flow study can be done excellent with high accuracy, and aortic and mitral wall analysis can be done beautifully. Some of the images you like to see there. This is my team at Asian Heart Hospital where my colleagues are there, and these youngsters are doing excellent job today. Fortunately, this is 25, more than 35 years I have been doing here, but youngsters have taken over. Now, what is more important, the 2D technology or transdisciplinary technology is excellent at the bedside. It is very good technology and you can do 24/7. There is no doubt, and it is accessible to the patient and everything is good. But there are technological limitations. There are areas, there are critical areas. You can compare yourself when you want to see that. Now see here tissue contrast. You can compare yourself. 4-chamber view in the please run the video. 4-chamber view, it is automatic. 4-chamber view in the 2D echo and 4-chamber view in cardiac. I had given the full, I have checked it please. Put automatic, it will run. So this is the advantage where apex are not very clearly defined on 2D echo and epicardial area is not very clearly defined. That's a technological problem. Please run that, just see. So what you need in CMR, a good scanner, but gradient system should be very good, and 1.5 Tesla is good enough today. And I am doing my all work in 1.5 Tesla with a good software and good ECG vector gating that. Now this is the what vector gating can be done here. Basic image, a cardiologist should also know what are the basic sequences, which is scientifically given name, black blood images, white blood images, and phase contrast, ventricular imaging, perfusion imaging, and post-contrast imaging, early and delayed enhancement. There are a lot of advances happening, so you know about that. I will discuss in few slides here. T1, T2, and T2 star mapping, and 4D flow has added the advantage today. Now, this is the study. Why cardiac? You can see this study here very well, where all different types of images this different type of software can be carried out here, studies can be carried out, and you can be one-stop shop. This is what I want my cardiologist to see, like this images in one plane. You're not seeing one after another, after other. Please sit comfortably. You see from 3-chamber up to the short axis view, base to apex, everything is seen very clearly. You can see your hypokinesia, akinesia, dyskinesia, whatever wall thickness, measurement, wall, everything. You sit, take your own time and see nicely. You'll be able to see out at one shot here. This is what we have been doing here. And this is ventricular function where it is absolutely ejection fraction is very high. In certain critical areas, you can always use. When you need in trouble, when in trouble, ask for MRI. That is the way I say. And these are all data has come very accurately, very high. We have been doing very regularly at Asian Heart Institute today. Now, this is what mass measurement can be done nicely on the delayed enhancement. So you can, the cardiologist and cardiac surgeon can decide what percentage of muscles are involved and how much scar tissue is there, and you can decide your management. This is what exactly parasternal view which you see on the echocardiography there, and you can decide very clearly here LVOT three-chamber view. Okay, similarly you can do your regional assessment. Bullseye is there, 17 segment can be well demonstrated. And this is for the postgraduate if anybody is there to know the coronary artery perfusion territory in different views. And my clinical application will be ischemic cardiomyopathy, and there are a lot of overlaps, symptoms and findings with the non-ischemic. So it is important for not only for radiologists, for a cardiologist to understand what type of enhancement pattern is there. The myocardial viability is a delayed enhancement. It's a scar, late gadolinium enhancement. Only black and white, your confidence level is almost 100%. You can say which looks black is normal, which looks white is abnormal. And this is what clinically, what is viability, dysfunctional myocardium with potential for recovery following revascularization, and by definition, myocardium that is alive. And this is what all over the world available today. And I will say still MR is definitely come up with good, very high standard. Scar, how does it work? It takes advantage of gadolinium, more gadolinium contrast. That's why it looks brighter because of T1 shortening. And there are two mechanisms. One is washing out and wash out rates. And normal tissue is small interstitial space. Acute MI or scar take a large interstitial space. The viability scar technique is excellent quality because of the spatial resolution and tissue contrast. And mind you, no ionizing radiation at all. Hardly any contraindications, and nephrogenic systemic fibrosis is very, very rare in the long run. That you have to be careful because of the contrast, and it takes viability. First perfusion, as you see in the nuclear medicine, you can lateral wall, you can see hyperintensity very clearly defined. And this is what 58 years female diabetic effort angina for 3 months. Adenosine stress perfusion was carried out, and you can see here the first row stress perfusion image, hyperintensity is very clearly defined. Rest perfusion, normal it looks, and third, fourth row, if you see late gadolinium enhancement is absolutely normal there. And this patient, RCA territory was there, patient went for angioplasty. Again, example, there many a times every month, at least I get one patient where they want to differentiate thrombus from a myxoma or some other tumor here. So this is the technology which will definitely help you out very clearly. Microvascular obstruction will behave like this. Don't get confused here. Hyperintensity surrounded with the hyperintensity, and it is acute microvascular obstruction. Viability single, sometimes some arrhythmic patient I need, then I have to do very fast here. So I have got viability single shot imaging system sense, and where you can demonstrate image quality like this. Now let us understand this slide. I want cardiologists to understand if it late gadolinium enhancement in the short axis view, thin subendocardial, dense subendocardial, near transmural and transmural patterns, they will behave like this. And interpretation is so simple. You can see the color coding here. Normal and non-viable, viable tissue can be seen nicely. LG pattern, again ischemic and non-ischemic, there is a lot of overlap. You must know this. And this is the pattern where you can demonstrate mid-myocardium involvement, linear pattern, dense pattern, and sand-like interstitial fibrosis, and epicardial lesion, how they look. And this one slide where all these diseases, you know of these diseases which can be diagnosed by MRI very clearly with confidence. Of course, the pattern is little non-specific. So you have to use your clinical sense. And this is example. One slide will give you all the answers of non-ischemic and ischemic very clearly. You can go through transmural, subendocardial area and other areas, other different diseases, amyloidosis and other diseases can be well post-cardiac transplant patients, how it will look, and even myocarditis, sarcoidosis and other disease, how they look. Exactly you can decide from this. Unfortunately, there is a shortage of time. This is a very interesting subject which could have taken little more time. And here example here, now see hypertrophic obstructive cardiomyopathy, SAM is so clearly defined even in the 4-chamber view. You can do 3-chamber view. This will fall down, please. This will fall down. Yeah. Multiple patchy enhancement in SCM is very clearly defined. Late gadolinium enhancement with the interstitial fibrosis are well seen. Fibrosis, CMR, and even typical RV insensitive site scar is seen so nicely. Amyloidosis. Amyloidosis is one condition where you can diagnose very nicely here involvement of the right ventricle musculature and left ventricular musculature. Sarcoid is one of the common condition in our country and should be also kept in mind. Sarcoid can behave like this, patchy enhancement in pattern, and sometimes sarcoid is like this. This pattern also is a sarcoidosis and should not be confused many a time mediastinal lymphadenopathy. And in our country, please do not forget, when I said sarcoid, it turned out to be tuberculosis. So cardiologists, please keep in mind TB, myocardium also when you talk of sarcoidosis, because the prognosis is different, treatment is different. Here, we don't have in India MRI PET available today, but this will change the whole trade if it is available, though it is expensive. LG PET combination intensity, so nicely seen here. Valvular heart disease is an excellent evaluation, and you can see here tricuspid regurgitation with ASD, epsilon features, and you can do tricuspid regurgitation, vena contracta, phase contrast study nicely, and severe form can be judged. This is a lateral eccentric. You can see here again Marfan syndrome, aortic regurgitation, qualitative and quantitative. You can see nicely study can be done. Other areas where you can overlap is right ventricle, which is overlooked, and you can demonstrate nicely right ventricular arrhythmogeny, and where fat can be, you can see nicely fat deposition in the right ventricular musculature, and you can see here a dyskinesia nicely. Myocarditis, and especially we saw a lot of patients due to myocarditis in the last 2 years, and we can really diagnose nicely. In fact, one of my residents got that, and I followed it religiously, and he's doing well now after the treatment. Constructive pericarditis is one area where septal bounce is classical here, and see in the grid technique also very nicely seen here. Other example of constructive pericarditis, bilateral pleural effusion, CCF. Recent advances are most important which are happening, and unfortunately, not many, unfortunately we don't have those software available to many centers, but things will change today. T1 mapping, T2 mapping, a new application like ion deposition, T2 star mapping, and these are the various available diseases which can be sorted out nicely with this short disease. And here I just got this from the radiographic there. This will change the whole technology where sinus holy flow source, sinus venosus, ASD, and dilated right ventricle so nicely. This can be done with contrast or without contrast, such a clarity of the image. And this is what aortic lesion and root of the aortic lesions can be well assessed with this 4D flow technology. And this is I got last year. This is somebody, Reza is doing wonderful job, and my confidence level is not very high with MR coronary. The day it comes, it will change the whole concept. Today, CT angiography, my confidence level is 98%, including calcium also. But MRI cannot say that. And I am stuck up here at this level. This is for the cardiologist to decide where do we stand today. And this is what I created my department. See, MR coronary angiography, I'm trying. But it was a normal patient, good heart rate. Let us see 2 cases and conclude, please. I have got 2 minutes. 2 minutes wasted. This is what the exact ischemic heart disease. You can see a pseudoaneurysm from the left ventricle, and this you cannot see on the 2D echo, and it will be difficult on transesophageal echo also. So you need MRI. So these are the areas where MRI scores over, and your health is your When in trouble, you ask for MRI. That is the criteria I choose. And let us see, this is a case I have, my cardiologist, famous cardiologist in Bombay, saw for first time. That's why I'm showing this case where MR has solved the problem. Young lady, 27 years, clubbing since childhood, fatigue, low saturation on study, no hypertension. And you can see here, right ventricle is showing thin membrane, double ventricle here, right ventricle, and ASD is seen very clearly. And these are the examples where you can see the membrane nicely. And here, I guided cardiologists to demonstrate catheterization, to find the septum there, how does it look like that. And this was a case where it is waiting for a surgical repair now, and my cardiologist was very happy because it came first time for such demonstration. And Doppler confirmed here, ASD was confirmed, and this was the, you can see here, I just got these studies from my cardiology friend who gave me like this, and RV membrane is seen nicely, and a double chamber right ventricle is a rare congenital heart disease. In the future scope, typical scan time less than 15 minutes, indication based focus protocols and contrast free technique are happening, and that is what I conclude here. And acknowledgement, I had an opportunity to work all Cleveland Clinic, Texas Heart Center, many NIS center, many all the heart center in America. More than that, I had visited and worked as a fellowship program, and I'm grateful to Scott Flem for all this happening. And salute to Sir William Rongen, who discovered X-rays in 1895, and where we are all earning lavishly because. And salute Sir Mukund Joshi, who was my teacher, a great teacher, one of the greatest sonologists of India, and well known all over the world. Mona will agree for that. And thank God, I salute Sir Ganesh ji. This is a beginning of new era for coronary angiography or MRCA angiography or whatever you can cardiac MR. Thank you so much for your kind attention.